नमस्कार, सत श्री अकाल, आदाब, गुड मॉर्निंग, गुड आफ्टरनून एंड गुड इवनिंग जहां से भी आप हमें सुन रहे हैं. थैंक यू फॉर ज्वाइनिंग आवर लाइव सेशन. माय नेम इज कुंचन. हम आपके होस्ट और दोस्त फॉर टुडेज एफबी लाइव सेशन. Indian origin folks living in US. If parents are visiting from India and you are looking for medical consultation, well, look no further. eGlobalDoctors has your back. In today's Facebook Live session, we will be exploring and providing more information about pre-operative care. Dr. Umesh Sharma is a consultant with the Department of Hospital Internal Medicine and an assistant professor of medicine at Mayo Clinic College of Medicine. He's also a fellow of American College of Physicians, Society of Hospital Medicine, American Association for Physician Leadership, and American College of Healthcare Administration. It's really nice to meet you, Dr. Umesh, virtually. Thank you for sparing time. I know you're super duper busy. Welcome to eGlobal Facebook and Insta Live session.
Oh, thank you, Kunjan. It's just a pleasure being part of eGlobal, and thank you so much for this opportunity to talk to you, an audience.
Thank you. Pleasure is ours. So what do you say, Dr. Umesh? Should we actually dive into our today's topic?
I think it's the right time. Please do. Thank you.
Okay, so I know that our topic is pre-operative care, but when I was doing your intro, I saw the word medical, internal medicine, hospital. So I'm going to open the show with what is hospital medicine, doctor?
Thank you so much. So hospital medicine is a branch of internal medicine that really deals with inpatient care. So what has happened is, especially last almost 20 years or so, people are getting more complex, our patients are getting more complex. In the past, you had the same physician work in the clinic, work in the hospital, go back to the clinic, go back to the hospital, back and forth. But what would happen at times is sometimes people would get too complex in the hospital. You cannot be leaving them sick and then crashing and have a full panel in the clinic. So that's where the division started, where people decided, people like me decided, well, let me just focus on inpatient care. And some folks decided to just be outpatient doctors. So we are internists who primarily focus on inpatient care when somebody gets hospitalized, whether it's medical complications like diabetes, hypertension, heart disease, what have you. At the same time, we do that bread and butter, but also co-manage surgical patients with our surgical colleagues, and that's where we provide the co-management, consultation, and perioperative care. That's the topic today.
That's interesting. Actually, I did not know about that. So thank you so much. So with that, I will start our question answers for our today's topic. So what is perioperative care and who might need a perioperative care?
So as I mentioned earlier, a lot of our patients undergo surgeries, right? Whether it's hip, knee replacement, minor surgeries like cataracts, or breast surgeries, or major surgeries too, like cardiac bypass, transplants, brain bleeds. So any surgery is a risk for the patient. And basically the perioperative care is to make sure we bring those patients through that phase as safely as possible. So you have the preoperative care, intraoperative care, and the post-op care. The whole three steps, pre, intra, and post, is a perioperative medicine. And physicians, along with anesthesia and surgeons, we all team together to make sure that patient journey is as safe, as risk-free as possible. So basically, to answer your question, everybody needs it in some way, shape, or form.
Okay, so it's 3 stages: pre, inter, and post, and
Correct.
That's where you and your expertise come in. Okay.
Yes.
Okay. So there are, like you mentioned, there are 3 stages. I'm pretty sure there are a lot of people who are playing actually important role, doing their due diligence. So when a patient is undergoing a surgery, what is the role of a physician and a surgeon?
So the main thing of the role of a physician is to be a risk manager. So basically trying to figure out what's the risk profile for the patient, what's the risk profile for the procedure, and try to minimize that as much as possible. Obviously, there are some factors that are reversible. There are some we cannot, like age in particular is not reversible. Somebody who has chronic medical conditions, if they are not managed properly, we can optimally manage those. So those could be semi-reversible. So the role is pretty much a risk manager, get somebody through that period as safely as possible. So the physicians, we do consult, we try to figure out, what kind of risk profile the patient is in, what kind of risk profile the operation is it, and then work with our surgeon team to give them recommendations and guidelines around the perioperative care. At the same time, we co-manage at times, depending on different operations, we co-manage with the surgical team. So everybody has a role to play. The key here is communication of our recommendations, working with the patients, their families, the surgeons throughout this perioperative phase.
Wow, so it's a really chain reaction kind of thing and has a dominoes effect. That's actually amazing to know that a lot goes on with the word surgery and perioperative care. So, how do you decide if a patient is at high or low risk for surgery?
That's the question, right? That is the main question that we have to answer. Like, you know, if a patient has to go through an operation, is it worth the risk, right? You don't want to expose somebody to more risk than they already are. So again,
Mhm.
what we figure out is, so it's a much detailed question, but I'm trying to simplify. I'm going to try to simplify as much as possible. So the first thing we ask is, is this an emergency? If it's an emergency, then all bets off, right? You gotta get to the operation as quickly as possible. Example, somebody has a ruptured appendix. Somebody has active, bowel obstruction going on. So there you don't think. What you do is call the surgeon saying this person is sick. They need to go to the OR right now. So you get them to the OR and try to manage the risk post-op. So that's one thing. The second question you ask is, are they having active heart attack, active cardiac ischemia? So the reason I'm saying this is because we see those patients in the hospital on a routine basis. Somebody comes in sick. So first thing you ask is, is that an emergency? Are they having active heart attack? If the answer is yes, you fix those two things first. If the answer is no, so it means they're stable. So you have some time to figure out, well, how am I going to risk stratify? Then the third thing you ask is if this person has a potential of having a heart attack or a heart disease, are we going to fix it at this time? The reason I'm saying this is if the answer is yes, then you try to do a quick stress test for them. If the answer is no, then basically you go through the process, get them to the operation, and do your best to manage the medical risks. So that then once you answer those three questions, then the question is how risky is the procedure? Because remember, you're going to have risk from surgery itself. Some surgeries, as I mentioned earlier, is going to be low risk, like cataract, kind of very minimal risk operation. Obviously things can go bad, but typically for the average patient, things should not go bad in a cataract. On the flip side, if it's a major vascular surgery, like you're having a cardiac bypass done or a aortic kind of bypass, or some kind of major blood vessel procedure, a risk of bleeding, risk of major fluid shifting. So those are very high risk operations. So there's risk of operation, and obviously at the same time, you got to calculate the risk for the patients. So if somebody is younger, in a good physical condition, they're going to be a much favorable risk profile than somebody who's elderly with multiple medical issues like hypertension, diabetes, heart disease, stroke, kidney failure, COPD or lung disease. If those are, especially if those diseases are not managed properly, they're going to be at
Mhm.
very high risk for having perioperative complications, in particular, heart attacks, lung problems. So basically, we look at risk of the procedure, risk of the patient. And the most important thing would be how fit are you? There are
Mhm.
different ways you can know how fit somebody is, but the rule of thumb or the simple thing would be if a person can climb one or two flight of stairs with a bag of groceries without having huffing and puffing or chest pain, technically they should be in decent shape. If somebody can walk at a fast pace and have a conversation with their friend, they they should be in decent shape to undergo a procedure. So a lot of things go into the calculation. So as I mentioned earlier, if it's a high risk procedure and a little higher risk person, and they have a limited exercise tolerance, then you want to stress them to see can they tolerate the stress of operation. If they pass the test, then you should go through the operation with hopefully minimal complications. If they fail the test, it means they have underlying significant heart disease that needs to be looked at first before you expose them to the risk of operation. Then you call your cardiologist and ask them for help. And these patients may undergo stress tests. And as I said, if it's positive, they might undergo angiogram and stenting and fixing of the blockage. So a lot of things going on, but the bottom line is somebody who's healthy technically should have a event-free surgery. Somebody who's otherwise unhealthy or has a lot of chronic unmanaged medical issues are going to be at a much higher risk of complications.
Well, thank you for that. So you guys are actually always on the toes. So I did not expect that there would be so much information behind a simple question. And I know after the interview, after the interview, I'm gonna be carrying some grocery bags so I can see which category am I falling in. So you did touch briefly upon a word stress.
Mhm.
So I'm gonna ask a question. So you know the word surgery stresses me. I had a dental surgery. So, how do you know that who needs a stress test before surgery?
So, I think the key is to figure out what kind of physical condition they are in, right? So if you are a otherwise younger, healthy person, just somebody like you know, who's otherwise younger, and I suppose if I ask you to run a mile on a treadmill under 10 minutes, you should be able to do it. So you should be in a much favorable risk profile and technically should not need a stress test. On the flip side, I have somebody who's, who's 65, 70-year-old, has history of hypertension and maybe early heart disease, and they haven't had a stress test or any kind of imaging over the last 6 months, and they are undergoing a little high risk surgery, like anything that's between the chest and abdomen. Say, for example, if they need a lung mass removed, then I would do a stress test on them. And depending on if they can walk, we can do a treadmill stress test. If they're unable to walk, then there's nuclear or chemical stress test where you give inject a chemical, see the heart behaves, and hopefully they pass the test. It means if they pass the test, that you can correlate that their body is strong enough to undergo the stress of surgery successfully. If they fail the test, then there is a possibility they may have a significant underlying heart disease. Significant means they may have 50, 70% blockage of one of the blood vessels. That's probably why they failed the test, the stress test. And those are the ones you want to refer them to cardiology before you start doing any operation on them, which is elective, which is not urgent. And
Mhm.
hopefully get that fixed first before you stress them even more. Because the last thing you want is to do an operation on somebody who's on that risk profile and they end up having post-op complications like heart attacks or heart failure or something like that, which potentially you could have avoided. And that's the role of a risk manager or a consultant.
Okay, perfect. So stress tests are important. Please don't stress. I know the moment we said don't stress, the stress automatically comes to us. So before I go to our next question, I just want to quickly tell everybody that we are live on both platforms, Facebook and Instagram. So hop on your social media and we bring to you interesting topics. And if you have a very boiling question, we have Dr. Umesh. We are talking about perioperative care, so please put it in the chat and we'll answer that. With that, I do have a Facebook question that came through our Facebook Live, Doctor. So I'm going to be asking that to you. So one of our listeners want to know, how do doctors handle alcoholic patients for surgery?
That's a very good question. One thing I'll be surprised. I don't know if you guys know. A lot of people. This might be going a little tangent, but something to think about. What you consider alcohol, a lot of people may not consider alcohol. For example, a lot of people drink beer on a regular basis. And if you ask them, hey, do you drink alcohol? They say, no, I don't drink alcohol. How many beers do you drink? Well, I drink two a day. So for some people, alcohol might be hard liquor. So you got to be very careful. So the biggest thing is if you're drinking on a regular basis, your body gets used to the alcohol. As we all know, alcohol makes you sleepy and it affects your certain receptors in the body and suppresses them. And if you stop alcohol, especially if your body's used to drinking, say 2, 3, 4, 5 drinks a day, and you suddenly stop it, it's like, your car is going forward, but you put the brakes on. All of a sudden, you take the brakes off, and the car just accelerates. That's what happens to the body. The body just goes in a storm where all of a sudden there's nothing blocking those receptors, and you have all these extra chemicals, and you just go crazy. So basically, people have severe withdrawal from alcohol if you stop alcohol suddenly. Number one. Number two, sometimes there are some people who drink a lot or drink for a long time, the liver gets damaged. And if you have existing liver damage, that's a problem for operation. And depending on the extent of damage, if it's really damaged, you're going to be at very high risk for any operation. If it's little damage, then you can, we will have to be very careful with some of the medication, because a lot of medicines get metabolized or broken down by the liver and kidney. If your liver is not working properly, whether it's pain medicines or anesthesia medicines or what have you, they may have a little longer effect. Not to mention, liver produces chemicals that makes your blood thick. If your liver is not working properly, your blood becomes much thinner than a normal person's blood. Consequently, you're going to be at much higher risk of bleeding, just the fact because your liver is not making those chemicals. So obviously, those things you have to be mindful of. You have to know, is this just somebody who's drinking alcohol with no liver damage, or somebody's drinking alcohol with liver damage? Whole different ball game. But the key is to be mindful. Ask that question: hey, do you drink beer? Do you drink alcohol? And then figure out, if the answer is yes, screen for liver disease, and then based on that, they may or may not be a good risk candidate for operations.
Well, so thank you for that, and thank you for shedding light on that. So hopefully whoever asked that question, you know what you have to do. If you're an avid drinker, please slow down. Drink responsibly. So we talked about drink. So let's talk about smoking now. So how much is the patient with a smoking habit is actually at risk during the surgery?
So the biggest thing is, again, it's just like alcohol, is how much you've been smoking and for how long you've been smoking. So typically, an average person, if you're smoking 1 or 2 packs of cigarettes a day for about 10 years, you get enough irreversible lung damage. So you may have something called chronic bronchitis or emphysema or COPD. That means your lungs are damaged enough. So anything's going to be high risk. So your lungs are damaged, you stress with operation, you may do poorly. So that's one thing. So ideally, you should stop smoking at least a couple months before the operation. There are some studies which have, so there's some data out there where if you don't stop smoking, you keep smoking, that itself is bad. But if you stop smoking within 1 or 2 months before the operation, you may also have some bad outcomes because your body is used to smoking, and also you stop smoking, the lung kind of becomes hyperreactive. You start secreting more sputum and phlegm. That itself may cause complications. The bottom line is, don't smoke. If you do smoke, try to stop it at least a couple of months before an elective or scheduled operation.
Okay, perfect. Thank you. So since we are talking about risk, I'm going to stay on the risk topic. The other risk, and the word that we have been hearing quite often, is obesity. So is obesity another risk area? And what are the risks associated if a person who has obesity is undergoing a surgery?
Typically, one thing unfortunately does happen is, as people get bigger and bigger, the body mass index goes more than 25 or 30. That's when you're at real high risk for complications. One of the bigger complications we have is called sleep apnea. Sleep apnea is where your neck is smaller because you have a little more body mass, and you cannot see the posterior pharyngeal wall. Those people are at risk of having respiratory compromise, where you stop breathing, especially if you get anesthesia type medicines. So you have to be aware. So when you're screening people for, pre-op consult, you got to see, what's the body mass index, how heavy are they? Can you see the posterior or the back end of your throat? If you cannot see the back throat and neck is chubby, these folks may be at high risk of sleep apnea. And that's when you want to let your anesthesia colleagues know, hey, this person's bigger. Be careful during the operation. They may be at risk of apnea. You stop breathing. They may need a lot more ventilated support after the operation. They may have prolonged recovery. So that's one thing to remember about obesity. The other thing would be, especially if obese person, they have trouble taking deep breaths after the operation. They may be at risk of lung collapse, atelectasis, where you have an operation on your belly, you don't take deep breaths, the lower parts of your lungs collapse. Risk of atelectasis or lung collapse, and consequently pneumonia. So those are the main things you want to figure out: is do they have sleep apnea or risk for sleep apnea? Or are they getting a chest or a belly procedure that puts them at risk of lung collapse and pneumonia? So you want to be just more aggressive, be watching them very closely. Especially in the post-operative period, make sure they have lung exercises, they take deep breaths, they have machines that helps them open the lungs up. So those things you want to be kind of vigilant and give those folks that resources.
Okay, wonderful. I'm sure a lot of people are benefiting. I know that I am for sure getting a great information. So with that, we have another question from our Facebook Live, doctor. So they are asking that, can you please help with post-operative stress and how to handle that stress?
So what does happen though is like, think about, right? Do you want to have an operation? I don't. So anybody has something like an operation, you get put out of your element, right? You don't feel you in control. Number one, there's always this stress or anxiety about the unknown, right? Well, I'm gonna get even simple things like I'm gonna get a dental, procedure done. I don't know what's gonna happen. They're gonna drill in my teeth. They're gonna give numb my like my jaw. So even those simple things is gonna cause stress. And imagine if you have to have a big procedure, heart bypass, or God forbid, a cancer surgery. Those things do put a stress on the person itself and their family. And that's where you have to be mindful, and then that's where you counsel the patients, like saying, and then especially if you have data to back yourself up, saying it's a low risk surgery, you should be okay. We're here to help. We're going to monitor. Or if it's high risk surgery, and that's where counseling and supporting the patient and the families is going to be crucial. And then and having empathy to understand that patients are going to be stressed, they're going to be anxious, they're going to be afraid, they're going to be out of their usual comfort zone. They'll be in a foreign place where it's a hospital where things don't look like their home. They would not be in their own bed. So a lot of things coming together. Again, that's where having empathy, holding hands, sitting down, especially getting the family together to care for the patient is going to be crucial to manage that stress.
Okay, thank you. So hopefully whoever asked that question, you got a little bit insight that how to manage and handle the stress for you and for the person who actually underwent the surgery. So with surgery, there's always pain. So my next question is, and we all have different thresholds for pain, right? My threshold is different from yours is different from
Correct.
someone else. So how do we manage the pain threshold during a perioperative?
So as you rightly mentioned, everybody has a different threshold, and every operation is going to cause different pain. So pain management is one of the essential parts of perioperative care. The key is to realize there will be pain and try to optimize the pain management with the kind of pain medication somebody is getting. And there are different options. You can either use oral pain medicines, you can use IV. There's some topical pain medicines like patches. Sometimes people get drips on nerve blocks and pumps. So there are different ways, different options. The key is to use just the optimal amount without causing a lot of side effect. And one of the main side effects we worry about is especially somebody's getting narcotics type pain, like morphine type pain medicines, is lung depression. So morphine makes you sleepy. It affects your breathing. A lot of people, have slow breathing because of morphine, because the body gets relaxed and it affects the receptors on the body. Second thing would be constipation. And third thing, sometimes pain can have opposite effect where people get confused because you're not thinking right and you're in a different setup. So that's exactly where you want to give enough to get optimal pain control, but not too much. And that's where walking the fine line and be mindful of what the side effects are and have a daily checklist of you giving optimal pain control. And as the pain gets better, you taper down the pain medicines and then wean people off the pain medicine. That's a process of pain management during the perioperative care.
Wow, that's actually good to know. And I'm so glad that we have people like you who are actually taking care of. Hopefully, I don't have to see you in a setup like that. But if I do, then I'm relieved that you are there. So we touched upon blood pressures,
Mhm.
diabetes. So if a person or a patient who's going to be going for a surgery and has blood pressure or diabetes or heart medications already they are taking it, any advice during the surgery or after the surgery for people who are taking medications?
So usually these are really important medicines, the blood pressure medicines, the heart medicines, what have you. We tend to continue those in the perioperative period, with some exceptions. One of the exceptions is that there's a type of medicine called diuretics, or they tend to draw water out from your body, and sometimes we use them for blood pressure control, or if somebody has heart failure, we use that. Sometimes we tend to hold those on the day of operation. The reason is, on the day of operation, some people may be most people are empty stomach, so they may not be
Mhm.
getting as much volume sometimes. after the operation or during the operation, they may lose some blood, lose some volume. So you don't want to give them diuretics or the medicines that take water off the body, and all of a sudden their blood pressure drops. So usually we at
Mm.
least hold on the day of operation. Next day, based on how things are going, we may restart them or hold them even longer, especially if there's some complication during the operation, like a lot of bleeding, or they need a lot of fluids. There's some other complications, like sometimes you get minor kidney injury and stuff like that. So, but typically we tend to continue the heart medicines and the blood pressure medicines usually during the intra and post-op period, unless there's a complication and things like that.
Okay. So whatever the regular medication is, it's okay to take them after the surgery unless or until there are some complications.
Correct. Usually, in most cases, yes.
Most cases. Okay, thank you. So, in surgery, whether you're cutting someone, I don't know what the right medical term is. For me, it's like there's a surgery, there's a knife involved.
Correct.
So there is there is a risk of blood clot, and I've
Correct.
heard this term. I don't know too much
Mhm.
about it, but what is the risk of blood clot during the surgery, and how can it be avoided?
That's a great question, and I think it has got a lot of attention in recent years. Where, you know, uh, usually there are different risk factors for blood clotting, right? One is if you don't move. I'm sure you've heard stories where somebody had a long distance air flight, and all of a sudden they had a blood clot in their legs. So not moving around is a risk factor. Having an operation, somebody, as you rightly mentioned, cutting and having like tissue trauma is a risk for blood clots. So typically the post-op period tends to be a high risk for blood clots, especially if you have a history of blood clots and other conditions. So usually if it's a low risk operation where you expect somebody to be up and about, they don't need a lot of like a medical intervention for preventing blood clots. On the flip side, somebody's bigger person, they're expected to be immobilized for a while. For example, somebody had a knee replacement or hip replacement, they would not be walking right away, right? It'll be a while before they start walking. So we give them blood thinners. And typically the typical blood thinners are usually heparin or a medicine called Lovenox. Sometimes our orthopedic colleagues, the bone colleagues, use high dose aspirin. So these tend to prevent blood clots. And if somebody cannot take those, then you have mechanical compression devices like a squishy things that squish your caps and pump blood up and down. So that helps to prevent blood clots. But the key is to get up and get walking as quickly as possible after the operation.
Okay, so make sure that the normal movement is resumed with, some, of course, medical help and stuff like that. So we can avoid the blood clot. So does perioperative care affect the mental health? You did touch upon it when somebody asked the question about stress, but I want to ask, we are at a different place and time emotionally and mentally. So can it affect the mental health, and what can be done about it?
No, I can, as I said, think about it. Like if I am going to have a like minor tooth thing, I would not be as mentally affected. But if it's going to be major operation like bypass or major stroke, which could be debilitating or life-changing event, people, tend to naturally so is going to take up is going to have is going to affect the morale and going to have a big setback. And that's where being mindful of what's the impact on somebody's day-to-day life and the psychosocial environment. That sometimes we as physicians may or may not be attuned to, because we assume we sometimes we get a little narrow focused on just the medical piece, but looking at the bigger psychosocial environment is also crucial. And I think that's where, as I mentioned earlier, having the empathy to understand, putting yourself in the patient's shoes and just understanding from their perspective. Just spending one day in the hospital is a big deal. Like, sometimes we don't realize, at least on physician apps, unless you personally spend a day in the hospital, doesn't you really don't know what does it mean to be not, sleeping in your own bed, being in a place where you're not in control, people coming in and poking and prodding and doing stuff against, your tech wish. So those things do
Mhm.
happen. So even those simple things can cause stress. And then now you add to that somebody operating on you and you getting a major operation done. So those things do add up, and it does affect your mental health. And it's always good to be mindful. And that's where having yourself a positive attitude and giving that to the patient and cheering them, encouraging them to look at the positive, supporting them through the stuff phase in their life, whether it's you or your team and the patient's family is going to be crucial. And teaming up is going to be the key, and the communication is going to be another key.
Well, thank you for boosting the confidence and keeping up the spirits, high during that difficult time. I don't know how you do it, but kudos to you. Thank you so much. So let me see if we have any questions. I don't see any questions. So with that, it's going to be a wrap. Thank you, Dr. Umesh. It was a great informative session. And before closing, let me tell our listeners and our viewers that eGlobalDoctors have started a new diet consultation, nutrition and health. No insurance is needed. Reach out to the fast growing doctors network. If you are living in US and your parents are living in India, you can consult USA doctors. eGlobal Doctors have dedicated diet programs that includes Indian food. Yes, you heard it right. You diet and you eat your favorite Indian food. If you are struggling with diabetes, thyroid, and you want to join a detox program, there are 3 different programs: free diet consult, 3 weeks program, and 3 months program, along with dedicated coaches. So register today at eglobaldoctors.com and book your appointment to get a proper nutrition coaching. So Dr. Umesh, before I let you go, any word of wisdom that you want to share with our viewers?
I think the biggest thing to realize that is when you or your family member is undergoing an operation, think about it. It's going to be in a way, depending on what kind of operation is it, it may be a life-changing event. That's where being mindful of just being aware, what are the possibilities, and teaming up with your physician, your surgeon, and just be open about those communications is going to be the key. And just ask questions, basically whether it's side effects or the possibilities, outcomes. And that's where the more questions somebody asks, the more they're going to be aware, the more or rather the less you're going to be apprehensive about a procedure. So the key is to ask questions and then be more informed as you get through the process. And then remembering the physician, your surgeon, everybody's teaming up to get you through the process as safely as possible. And everybody's on the same page, and we are on your side.
Thank you so much. And we are so glad that you are there. So, well, there you have it. This is Kunjan signing off. Till we meet again, stay tuned and stay safe. Keep smiling always. Thank you, Doctor, so much.
Thank you. My pleasure.